pneumothorax. In this presentation, I need to talk about two topics: tension pneumothorax and open pneumothorax. In the beginning, tension pneumothorax. A tension pneumothorax develops when a one-way valve air leak occurs either from the lung or through the chest wall. Air is forced into the thorax cavity without any means of escape, completely collapsing the affected lung. The mediastinum and the trachea are displaced to the opposite side, decreasing venous return and compressing the opposite lung. Attention pneumothorax is characterized by respiratory distress, tachycardia, hypotension, tracheal deviation, unilateral absence of breath sound, neck vein distension, and cyanosis as a late manifestation. Causes of tension pneumothorax is mechanical ventilation, spontaneous pneumothorax, plantar chest trauma. Treatment. Attention pneumothorax requires immediate decompression and is managed initially by rapidly inserting a needle into the second intercostal space in midclavicular line of the affected hemithorax. This maneuver converts the injury to a simple pneumothorax. Definitive treatment for tension pneumothorax usually requires only the insertion of a chest tube into the fifth intercostal space, nipple level, anterior to the mid-axillary line. Open pneumothorax or sucking chest wound. Large defects of the chest wall, which remain open, result in an open pneumothorax or sucking chest wound. If the opening in the chest wall is approximately 2/3 the diameter of the trachea, air passes prefer through the chest defect with each respiratory effort, because air tends to flow the path of least resistance through the large chest wall defect. Effective ventilation is therapy impaired, leading to hypoxia. Manage an open pneumothorax by closing the defect with a sterile occlusive dressing large enough to overlap the wound's edge and tap securely on 3 sides. Tapping the occlusive dressing on 3 sides provides a flutter type valve effect. As a patient breathes in, the dressing is occlusively sucked over the wound, preventing air from entering. When the patient exhales, the open end of the dressing allows air to escape. A chest tube should be placed remote from the wound as soon as possible. Securely tapping all edges of the dressing can cause air to accumulate in the thorax cavity, resulting in a tension pneumothorax unless a chest tube is in place. Any occlusive dressing may be used as a stopgap so rapidly assessment can continue. Definitive surgical closure of the defect is usually required. And this is my presentation, and thank you for your listening. Goodbye.